Hello, and welcome to a highlight from a recent webinar on coronary atherosclerosis in cancer patients. I am Dr. Tom Murtaugh from the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we will hear from Dr. Tamar Polonsky. Dr. Polonsky is a clinical cardiologist at the University of Chicago. Today's highlight focuses on the use of diagnostic tools to reduce the risk of coronary disease in oncologic patients. I know you will find this discussion interesting.
So I'm going to be talking really about measurement of subclinical atherosclerosis. So really emphasizing that this is in people who aren't having symptoms, but we're trying to detect atherosclerosis early. Most commonly in the general population, this is done with coronary calcium testing. And the reason why coronary calcium burden has been shown to be so important is because of autopsy studies many, many years ago that showed that calcium scoring on a CT was about a fifth of a person's overall atherosclerotic burden. So it has very significant prognostic implications in terms of their coronary risk. This is mostly done on high-resolution non-contrast PET CT, so that's the advantage. We do not need contrast. It's very low radiation exposure. It's basically like 2 mammograms. And there's a method for scoring that's typically used called the Agatston method. And this incorporates the number of pixels that are calcified plus the density. And then it adds up a score for every coronary artery. So if you order one clinically, then you'll see a breakdown of the coronary calcium score for each coronary artery and then a total score. The median age in the general population, and we're going to see that this is different in people with cancer, depending on the cancer subtype, but that it's typically above age 50 for men and 60 for women. The one downside of coronary calcium testing is that it's rarely covered by insurance, but for many places, especially in the community, actually, it's pretty reasonable. As low as $50 is the lowest I've seen it, up to about $300. Next slide. So these are just examples of coronary calcium tests. So you can see here that the coronary calcium score here is 0. This panel on the right is an example of a person with just a little bit of calcium. You can see that fleck of coronary calcium over there. It's really only in the proximal part of the vessel. You don't see it going further along. This is someone with a more elevated score. And you can see not only are the actual pixels taking up more space in the artery, but it's actually going further along into the path of the artery. And then this is a person with a calcium score greater than 1,000 that's really going along the entire length of the coronary artery. So why do we care so much about it? Like I said, it has incredible prognostic significance. So this is data from the multi-ethnic study of atherosclerosis. This is a non-cancer patient population, but this is really the basis of the data that we have regarding coronary calcium and its prognostic events, prognosis for coronary events. What you can see here are these are healthy people in the community. And again, stratified by age, you can see that a calcium score of greater than 300 or an intermediate score, there's a significantly elevated risk of a cardiovascular event. And this red line over here crosses at the 7.5% mark, which is where we will typically think about starting a statin for primary prevention. So this is just another example of how the pretest probability of a coronary event is very important. So if you're looking at coronary events versus ASCVD including risk of stroke in addition to coronary events, what you can see here is that again, the pretest probability makes a difference. So in people who had low estimated risk based on their traditional risk factors, the risk was fairly low even at higher coronary calcium scores. but it's really in the intermediate risk participants where the coronary calcium score really starts to differentiate between people who are higher risk and lower risk. And so if you're not sure about whether to put a person, for instance, on a statin, a coronary calcium score can be very, very helpful because it de-risks people. So if their coronary calcium score is 0, that really tells you that their 10-year risk of a coronary event is quite low, and it would be reasonable not to treat them with a statin. By the same token, if their coronary calcium score is elevated, typically above, at the very least, 100, but actually in some populations, and we're going to talk a little bit about that coming up, that even in lower scores, it would be reasonable to start a statin. Next slide. So not only are we getting important information on a gated chest CT, which is somebody comes in specifically to get a CAT scan for that, but this is particularly relevant in patients with cancer, that incidental coronary calcium, let's say they have a CHET CT for staging, or they came in short of breath and they had a CHET CT to look for a PE. If you see coronary calcium incidentally on a chest CT, even if it's not gated, it has significant prognostic information. And so many studies have looked at just semi-qualitative or semi-quantitative assessment. And so you may see it referred to as mild, which generally corresponds to a calcium score of 1 to 99. Moderate would be 100 to 299, or severe in some studies greater than 300. Again, has very significant prognostic information. The downside is that that's very institution dependent. We are very lucky at the University of Chicago that our chest radiologists are committed to putting that in the report for any chest CT that's done, but there really are no firm recommendations from radiologic societies. And so it's not universal at institutions. And so you may need to look at the chest CT yourself to try to get some sense of a person's atherosclerotic burden. And so this was a really interesting study using actually AI. It was just published in JAC, the Journal of the American College of Cardiology, last year, where a group from Stanford took all the chest CTs that they had in all comers. So patients, but they did exclude people with known cardiovascular disease. And then instead of sending them back to the radiologist, which would have obviously been very inefficient, they used an AI deep learning algorithm to quantify coronary calcium. And they looked at calcium scores of 1 to 99, and then also greater than 100. And what you can see here is that as you get into higher coronary calcium scores, it again has prognostic significance. And again, and these were not people, who were followed in a cardiology clinic necessarily. Like I said, these are all comers in the Stanford Health System. And so even with that heterogeneity, an elevated coronary calcium score on a non-gated chest CT had prognostic significance. Sorry, I'm not seeing the arrows. So next slide, please. Thank you. So I wanted to share also how we approach coronary calcium testing and how we incorporate it into clinical decision-making, again, for a non-cancer population, just to get an idea of how we might apply it now in the cardio-oncology community. So this is a consensus pathway from the American College of Cardiology that was published in 2022. And what they really emphasize is that when decision-making is unclear, again, if a person is typically in the intermediate risk category, so 10-year atherosclerotic cardiovascular disease risk of either 5 to 7.5%, or greater than 7.5%, and you're still not sure for whatever reason that you want to start a statin, it would be reasonable to get a coronary calcium score. Typically, a cutoff that we use for at least a moderate intensity dose statin would be a calcium score of 100. But if a person's younger, for instance, if they're 40 years old and maybe have risk factors, that's really too early for them to have a coronary calcium score typically of 100. But even a lower calcium score would be above the 75th percentile for their age and sex. And so it's very important to take that into account. And I think that comes relevant for our survivors of childhood cancer. Another important factor that they bring up in the consensus pathway is that a calcium score greater than 1,000 really warrants strong secondary prevention. So it's very reasonable to start aspirin. and to really even consider treating people to targets less than 55. Another important thing to think about is whether to rescan somebody. And so we know that in certain populations, they may have accelerated atherosclerosis, and that can come up particularly in patients who've had radiation or other cardiotoxic chemotherapy. Now, I wanted to also bring up abdominal aortic calcification because even though it's not in the heart, it also has prognostic significance. And when we think about cardio-oncology patients, many of them are not getting chest CTs, but they're getting a lot of abdominal CTs if they have some, for instance, a GI cancer. And so this is also data from MESA. So just taking it with a grain of salt that this is a primary prevention population without significant comorbidities other than things like traditional risk factors. But that what you can see here is that abdominal aortic calcium, that's the AAC here, above the 75th percentile was also predictive of CHD and CVD, and actually even total mortality, even more so than coronary calcium. It's really not understood why abdominal aortic calcium would be a stronger predictor than coronary calcium. It may just be that it's a sign of even more atherosclerosis. And so if you have it in your abdomen, maybe you also have it in your brain and you have PAD. It also is typically calcification that develops earlier than coronary calcium. So again, may just be a marker of sort of more aggressive atherosclerosis development. But if you see it in your abdominal CTs, in my eyes, that's an indication for, again, secondary prevention strategies. That's really not made it into the guidelines. So I will fully admit that that is personal opinion. But the observational data really is pretty impressive. Next slide. So I wanted to share also some tools that are available online. If you get a calcium score, again, keeping in mind that this is from MESA, so not a cardio-oncology population, but can be really helpful in terms of presenting the significance of calcium scores to your patients. So what you can do here, and I put the website, you can see there to the right, you put in a person's age, sex, and their race or ethnicity, and it'll calculate their percentile, age and sex adjusted percentile. And what you can see here is that for a 45-year-old Black woman, that a score of just 10 puts her, in the 95th percentile. And so even though that, is well below 100, that is a person that I would say, if I was seeing her in my clinic, that she is really on a fast track to developing worsening atherosclerosis later on in life, and that it would be really a time to get serious again about secondary prevention, things like statin therapy. Next slide. So there's another tool called the arterial age calculator. That is, again, also on the MESA website. In case you missed it the first time, honestly, if you actually just Google MESA and CAC, that you'll get to it. But what you can do is put in a person's age, sex, and risk factors. And so they'll calculate the arterial age based on just your risk factors alone. And then when you add in the coronary calcium score, it tells you what your arterial age is, again, taking into account your coronary calcium. And so that can also be a very powerful tool for communicating with patients to help them understand the significance. So, you're 50 years old, but you have the arteries of a 65-year-old, something like that. And again, taking into account that this is in a general population where these were validated, but I think still helpful. Next slide. So this is, I showed this figure. This is a really great review from JACC Cardio-Oncology that was published last year, summarizing, in I think a really comprehensive way, all of the ways that patients with cancer are at higher risk or for coronary artery disease and all of the factors that go into it. Some of it could be things like radiation damage. Other are specific chemotherapies that can cause endothelial dysfunction. It can be risk factors that develop because of a more sedentary lifestyle after people become less active. They may have weight gain with cancer treatment. And so there are many pathways that could then lead into that development of atherosclerosis. And this table, I think, also really nicely summarizes if we're going to think about using a biomarker or some other risk assessment tool in a cardio-oncology population, what are the things that we need to take into account? And this is taken from the same review article. Things like, is it widely available? Is it reproducible? They do mention as a con, as you can see here on the column on the right, that people may feel uh, uneasy or develop stress from it. I have to say, I use coronary calcium scoring a lot in my practice, both in my general cardiology practice and in cardio-oncology when I'm more so with incidental CAC. But I think that if you talk to people about it in a thoughtful way, that it doesn't necessarily mean they're going to have a heart attack, but it's just that they're at higher risk. And now we want to use all of the strategies that we have for prevention. I generally find it does not cause sort of excessive amounts of stress. Next slide. So I wanted to show some data looking at incidental coronary calcium in a cardio-oncology population. So this is a study that was published in 2021 of women who were undergoing CT scanning as planning for radiation for their breast cancer. And what you can see here is that a minority of women had very high burden of coronary calcium, but certainly a measurable number. There's some information here, not surprisingly, they were in their 60s. Women who had higher calcium scores tended to be older. Most had earlier stage breast cancer. And when we look at the prognostic significance of the coronary calcium, you can see in the next slide that it was still highly significant in terms of the risk of future coronary events. Next slide, please. Interestingly, the different models were adjusting for things like age and then also cancer treatment, but you can see here that the risk of both coronary artery disease, cardiovascular disease, and then actually all-cause mortality was significantly associated with the coronary calcium score. What was also interesting was that there was, next slide please, an interaction with whether or not women were treated with anthracyclines and then also radiation. And so this is, again, free information that we're getting at the time of a woman's cancer treatment that I think we should really be taking into account when we are thinking about sort of how we are going to bring them into survivorship long term. And I do certainly find that women or patients in general are sometimes reluctant to start a statin at the beginning of starting their cancer treatment, but that it's something I will keep in my back pocket for when they're done with their treatment. And then we think, okay, now we're going to think about, again, your survivorship. Next slide. This is another study looking at incidental coronary calcium in people who underwent a stem cell transplant for lymphoma. And the patients were stratified based on their calcium score. And again, what you can see here, sort of patients generally in their 50s with some risk factors. And what we'll see in the next slide is that the coronary calcium score, both for atherosclerotic cardiovascular events, which is the panel on the left, and actually all-cause mortality, was highly significant based on their calcium burden. On the left, it's stratified based on no calcium, sort of mild to moderate, and then CAC greater than 100. And for all-cause mortality, it was just CAC or no CAC. And you can, see that the Kaplan-Meier curves seem to really continue to diverge as time goes on. And so this is another population where people are generally reluctant to start a statin before they're going into the hospital, which is understandable. We also don't know if they're going to need other medications like, antifungals if they develop an infection that could cause liver toxicity. And so I will often hold off on starting statins until they're out of the hospital. We know that they're doing well, but that we sort of talk to them ahead of time that this is something to expect because it's going to help improve your long-term outcomes. And then I just wanted to share one more slide about, again, a breast cancer population. This was, again, women who were started on statin therapy before their cancer treatment. And this is observational data from Taiwan. And so, of course, we have all of those limitations of observational data. But what you can see is that the women who were on statins before their cancer treatment had not only lower all-cause death, but also actually lower cancer death. This confirms papers that were published, about 10 years ago from the Netherlands, and now yet another population. Again, if we're going to be uncovering all this coronary calcium, we want to know that treatments are going to work. So this is forest plots looking at the subgroups, and what you can see here is that it was really pretty across the board that patients tended to benefit. I also wanted to bring up the Stop Cancer trial, which was atorvastatin versus placebo and was published in JAMA last year. The primary outcome was looking at heart failure. These were lymphoma patients who were being treated with atorvastatin before anthracycline therapy. In older patients with greater doses of anthracyclines, it did reduce the incidence of a significant decline in EF. And so I don't think that statins should necessarily be given to everybody, but you could imagine that maybe somebody with a high coronary calcium score could also be a person to identify who might benefit more. And so just to summarize, on the last slide, how do I approach screening for atherosclerosis in patients with cancer? First, I look for incidental coronary calcium or abdominal aortic calcium. In younger patients, I think it's actually reasonable to start screening them 10 years after they've had their radiation, assuming they're otherwise low risk. That's, again, my opinion. I think it's, again, really important to look at age-adjusted percentiles, especially for childhood survivors or survivors of childhood cancer. Repeat testing is going to depend on your age and risk factors. And then going forward, when you decide what to do with those results, really based on their other risk factors and sort of general guidelines for prevention of atherosclerotic cardiovascular disease, of course, taking into account competing risk and goals of care. Thanks very much.
Thank you to Dr. Polonsky for helping us focus on reducing the risk that persists even after cancers are treated. This is at the core of what ICOS does. If you are not a member already, please go to the website and sign up. Also, don't forget to be in Minneapolis, Minnesota this September 2024 to attend the GCOS Summit. As always, we remind you to treat cancer, protect hearts.